in specialist weight management services. Very sorry I can't be there with you today. So today I'm going to be presenting about weight management and living with IIH, and I've treated several patients with IIH who have required support with their weight management. So this is an image that we see a lot in society, this image that obesity is caused by eating too much and moving too little. And although if we break it down to the very basic fundamentals, this is correct, actually society's understanding of obesity is incorrect. Obesity is a lot more complicated than what you eat and the exercise that you do. What you can see here is this very complicated image, and this is a map that we have from the Foresight report. And what we have in the very middle, in those little orange lines that you can see, is that principles of energy balance. So what we just saw in that previous image. But what we can see all around this very central image is there are so many factors that contribute to obesity. There are environmental factors, there are genetic factors, there are psychological factors, just to name a few. So society's understanding of obesity as this being very straightforward energy in and energy out model is actually very much underestimating how complicated obesity is. So don't worry too much about what's written on this slide. It's to show kind of the principles, going back to that kind of energy balance idea, that actually there's an awful lot of factors that impact on our weight management. And now in the field of obesity, we refer to obesity as a disease, very much as we would relate to IIH as being a disease. And we say it's a chronic relapsing disease. And what we mean by that is that it is a disease that we live with for our whole lives. Again, there are similarities with this idea as with IIH. It's chronic, it is lifelong, and it is relapsing. So although we may go through periods of losing weight, ultimately our biological drivers will encourage us to gain weight. Ultimately, what we know is that when we begin to lose weight, our bodies almost go into a slight panic mode. So particularly if we're losing weight quite rapidly, our body starts to think we're potentially going into the kind of caveman days of going into starvation, and our body panics. And ultimately what the body does is it's trying to protect us from losing weight, which would have been really helpful way back when, but not now when we're living in an environment where we have food in surplus. So essentially, when we lose weight, inside our bodies there are hormones that then elevate, that are telling us that we're hungry, and we have less of the hormones in our body telling us that we're full. Because when we lose weight, our body goes into this mechanism of trying to support us to regain weight. So ultimately, we may all have been in a pattern where we lose weight and we gain weight. We lose weight and we gain weight. And often this is a repeating cycle because, as we said, it is a relapsing disease. We also know that when we lose weight, our brain becomes more reactive to foods around us, particularly high sugar foods, high fat foods, and we get more of a sense of reward when we eat. And this is all because our body is trying to keep our weight stable. So when we actually want to try and lose weight, we're fighting against some very difficult biological factors that are going on inside us that we don't perhaps usually think about. So quite often when we have obesity or we're trying to manage our weight, it can feel like we're on a roller coaster. Feel like there's ups, there's downs, there's the loops, and ultimately we feel like it's a ride that we're never going to get off. We can lose weight, but ultimately we regain weight. And that's what I'm going to talk to you a bit about today, is actually how do we break that cycle of weight loss leading to weight gain again. So what's really important to understand, so as we said, is that society has this very basic view about obesity and actually is incorrect. It's not so simple as eating less and moving more. And this uneducation in society leads to weight stigma. So weight stigma is when there are negative attitudes towards a person because of their weight. It begins with stigma, so beliefs. It can lead to bias, which is where we begin to believe certain stereotypes about certain people because of this assumption. And then ultimately it can lead to discrimination, and discrimination is when people behave differently towards people who are of a higher body weight. And it may be something that you can relate to if you're somebody who lives with obesity yourself, but it is pervasive, so it is all across society. Weight stigma can be experienced in a lot of different settings. So we're not just talking about in the media, we're talking about in the workplace, we're talking about in schools, in exercise settings, in policies and campaigns, but also really worryingly, stigma is experienced in healthcare too. And if you just do a Google search of the word obesity or the word obese, we can find images such as these. So pictures of people without heads, just these torsos that you can see in the top left, people having fast food or junk food, people being sedentary, watching TV whilst eating a bowl of sweets, or that last image there of the lady in yellow looking very sad and very depressed. These are all stigmatizing images that we see a lot alongside newspaper articles, magazine articles, and ultimately it's not reflective of what people's lifestyles when they live with obesity. So if we think about sort of in obesity services at the moment, when we think about in the UK what people are experiencing, 88% of people who have obesity that were surveyed said that they have been stigmatized, criticized, or abused as a direct result of their obesity. Only a quarter of people with obesity felt they were treated with dignity and respect by healthcare professionals. And 4 in 10 people did not feel comfortable talking to their GP about obesity. That really sets the scene here of kind of the scale of the problem and the impact of stigma for people with obesity when they're accessing healthcare services. So what are the consequences of weight stigma? So it's this very commonly held myth that stigma can be beneficial. So shaming people about their weight, that will be helpful and it will shame them into losing weight, when actually we know from all the research that we have that weight stigma does not support weight loss. In fact, it is very damaging. It impacts on people's mental health. Experiencing stigma actually has a physiological impact on our bodies. So our blood pressure rises, our blood glucose rises, we go into a stress response, which actually has negative impacts on our health. When we also experience weight stigma, people then start to believe that narrative that they're being told about themselves, and that's what we call internalization, so believing what people are saying. It's actually associated with weight gain, particularly for sort of coping mechanisms in terms of eating behaviours. So experiencing stigma can actually have a negative impact on eating behaviours too. And ultimately, people are less likely to engage in healthcare if they feel they are being stigmatised. So that is a huge myth. We know that weight stigma, shaming people about their weight, scaring people about their weight, does not lead to behaviour change for weight management. So what I'll show you here is from a survey that we did among not people living with IH, but people who had obesity in general. And what you can see on the left is those contributing factors that lead to that healthcare experience for people living with obesity. So we've got the stigmatizing society around us. We've got the population's poor understanding about the causes of obesity, and also living in an environment that can be conducive to weight gain as well, when we think about the availability of food, about how all our jobs and lifestyles have become more sedentary. On the top, the PWO is people with obesity. And what we can see is that in various stages of the journey for seeking help with weight management, there are barriers to care. So quite often people with obesity themselves don't have that understanding about the real biology and causes of obesity, because they're being told in the media and they're being told by other people, and they're internalizing this belief that obesity is their fault, that obesity is easy to solve, it's easy to lose weight, just eat less and move more. Also, people with obesity tend to have this sense of responsibility, again from that stigmatizing experiences that they've had, that it's all their own fault and it's all their own responsibility. And sometimes people are reluctant to seek help because they feel that they are themselves to blame, which we know isn't true. We also know that in the healthcare environment, quality of consultations with healthcare professionals can be a barrier to weight management. And often healthcare professionals might not use the most effective treatments to support weight management. And I'll talk to you a little bit about the evidence base that we have for what are effective weight management interventions to support weight loss. So having the conversation, this might be something that you can relate to. So when you're with your GP or you're with your neurologist or you're with whoever is treating your condition, when you're dreading that conversation coming up, they're going to say, you need to lose weight. And the way that conversation takes place can either be incredibly supportive or it can actually be really damaging as well. So what we've got here from the IIH UK charity is they've done some questionnaire research with people living with IIH, and 8 out of 10 people were not happy with the way that the topic of weight was raised with them in relation to their IIH. In this word cloud here, we can see some of the emotions and some of the feelings that people reported when these conversations took place. And the biggest word that's standing out here is fault. And again, it's going back to that idea that people are feeling blamed for their obesity, that it's their responsibility, that they caused their weight management, or sometimes even that perception that you caused your IIH as a result of your weight. And ultimately, there's feelings of upset, feeling depressed, angry, awful, ashamed and sad. And this is an environment where healthcare professionals are there to try and help you and support you and to help manage your health condition. But sometimes the way these conversations take place can have negative consequences. So what we now know in our field when we work in obesity is the real importance of people first language. So we don't call people obese people anymore, and we shouldn't. It's about putting the person before the condition. An equivalent would be if there was somebody living with cancer, you wouldn't call somebody cancerous, would you? And it's the same with obesity. We don't call people obese. It's a label, and that is not the way that we should be referring to people with obesity when we're treating them. Instead, the language that we use should be referring to people with obesity or living with obesity. And I still see it a lot on letters from many healthcare professionals with the word, I saw this obese person. And this is not the language that we should be using. So when we look at some research that has been conducted about people living with obesity, what their preferred terminology is, preferred terms were objective terms such as weight, overweight and unhealthy weight, whereas the least preferred terms were extra large, chubby and super obese. What we also know is that when we put a word in front of that adjective, it leads to higher levels of disgust. So rather than somebody just referring to somebody as having what their BMI is, but saying a high BMI, saying extra large instead of large, and saying very overweight instead of overweight. And what this ultimately does is it gives the kind of gives the perspective to whoever is receiving this kind of language that they're far away from the societal norm. So putting that word in front of it is implying that somebody is different to the norm. And it'll be interesting to hear in your discussions, if in your letters or in your consultations with healthcare professionals, how they actually refer to your weight and the language that they use. So again, really useful research from IIH UK actually asked people living with IIH, how could the experience of being advised to lose weight be improved? And we've got some really interesting quotations here. So first of all, asking for permission. Is it okay if we can discuss the topic of your weight? Consent. It's a basic principle. Our healthcare professionals should be asking for consent to talk about our weight. Talking about exploring options and how that will then help you. Taking blame out of it, and that is the one word, that fault word that really jumped out on that word cloud, is as it is with any other medical condition, this is the problem, this is what we can do, and this is how we can help you to get there. Somebody's mentioned about the language that we just talked about, so getting rid of the word morbidly and extremely, because it is dehumanizing. It's not the language that we would use when we're talking about people. And then I think this is a lovely quote, actually, is saying that if we know that weight management is a really important part of treating IH, doctors and healthcare professionals really need to take the time to understand some of those issues that may be contributing to the weight management, rather than making it simple and simplifying it and saying, oh, it's easy, you just need to go away and lose weight, which, as we've already talked about, is not the case. And the other factor that came out from this work was this idea that people living with IIH were being given goals that weren't necessarily attainable, and even worse, and I hope you've not experienced it, but I guess there might be some discussion here as well, is that idea that healthcare professionals move the goalposts. So you're said you need to go away and you need to lose 5%, and then you lose that 5%, and then the healthcare professionals, it's not enough, you need to lose more, and it's demoralizing. And this is what people living with IIH have experienced. So being told, for example, to lose between 8 and 10 stone within 6 months, which is not possible. There is no way anybody is ever going to lose that amount of weight. 13% of your body weight, it's a huge number. Where did that number come from? Somebody was told to lose 5%, and then it moved to 10%, and people seeing that these goalposts keep moving. So what I did want to share with you is what the evidence does say about weight loss targets when we're living with IH. So we do know that around 70 to 80% of people with IH are also living with obesity. And we know that weight management is an important strategy when we're treating the disease. So previous research has said anywhere between about 6 and 10% weight loss can lead to IH remission. However, what we know is that even when IH goes into remission, because again, it's a chronic relapsing disease, actually regaining weight of as little as 5 to 6% could lead to reoccurrence of symptoms. And that's really important to remember when we know that obesity is also a chronic relapsing disease. Research that has very recently been published this week has actually looked at people after bariatric surgery who lose a significant amount of weight, and actually with more robust methods, how much weight loss might actually be needed to support remission in IH. And it sounds like a huge number, it's 24%. So actually we need to think really carefully about when healthcare professionals are offering you treatment, are the treatments that they're offering you the right treatments for the amount of weight loss you may need to help support improvements in your symptoms and hopefully lead to remission as well. So I'll talk to you about some of the strategies, because I feel it's really important that patients know what strategies are out there, because unfortunately quite often healthcare professionals don't. And we know that there are barriers with living with IH. So it's another sort of challenge that we have to weight management that we need to be aware of. And again, some really good research done by IIH UK looked at what some of the barriers were to weight management for people living with IIH. And I think what's really striking is the highest barrier that we can see right in the middle is fatigue. And we know that IIH as a condition is very fatiguing. And also mood. We know IH can have a huge impact on mood, some of the side effects from the medication, and pain as well. So we know that there are challenges that we need to overcome when we're trying to manage weight, and the healthcare professional that is supporting you with that needs to be aware of that too. When we think about weight management in general, there's lots of factors to consider. So it's not just thinking about dietary interventions and physical activity. Thinking about sleep. We know that sleep is incredibly important when you're trying to manage your weight, but also for your own well-being. Thinking about some of the psychological issues that might be driving some sort of eating behaviours, or that self-body image perhaps that is meaning that physical activity feels really, really uncomfortable. We know we've got low-calorie diets, which tends to be meal replacements. We've now got some medications that we can start using as well. And then there's bariatric surgery as well if other measures haven't supported a clinically beneficial weight loss or outcome in terms of symptoms. So I just want to highlight here is that patients that I see will often feel this kind of sense of failure if they've lost weight, but then they've regained it. And I almost want to normalize that to an extent, because if we go back to my very first slide, obesity is chronic and relapsing, and there are biological factors that are going to be at play here. That means maintaining weight is actually probably the most difficult thing. So this study here shows, with a really, really intensive 1-year lifestyle intervention, the average weight loss. But then we can see at 8 years, ultimately there was a weight regain, although people were still lighter than when they first started. So again, normalizing that pattern is quite normal. It's not a sign of failure. That is what we would expect to see in terms of biology. We've also got very low energy diets. So again, we see this weight loss, but ultimately we know that people will have, to an extent, some weight regain, but still be lighter than when they started. We've also got pharmacotherapy here. So we've got some exciting new medications that are coming out now that are really effective for weight management. And what you can see here is from a trial that's been published quite recently, which has shown a lot of weight loss whilst the drug is being prescribed. Now, what I want to highlight here is what happens when somebody stops the drug. And what I'm trying to show here is that obesity is a lifelong condition. We need to treat it lifelong. So it's not a case of taking medications and then stopping medications if that's the route we go down. They need to be prescribed lifelong. And then we've got bariatric surgery. So again, what you can see here is this really significant weight loss, but ultimately, even with bariatric surgery, there is an element of weight regain and then maintenance. But again, people are much lighter than they were when they first started. So this isn't to demoralize you that ultimately weight regain will happen. It's just that to some extent, it is normal to regain some weight, but the benefits are still there because you've still lost more weight from where you started. So in conclusion, when we're thinking about obesity management, and the approach I would take with my patients and the approach that I would hope you have with your healthcare professionals, is that healthcare professionals should be asking for permission to discuss your weight before going into that conversation. They should be taking the time to really assess some of the root causes that might be contributing to your weight management, and then advise. So advise what treatment options are available. And again, knowledge is power. So hopefully now you know that there are a range of treatments that you may be eligible for. It's asking about these with your healthcare provider. You should be set goals and these should be agreed upon. So it's not a case of the healthcare professional telling you what you're going to do. These should be a goal that you are coming to together. And healthcare professionals need to assist. So it's not a case of saying you need to lose weight, off you go. Assisting is where the healthcare professional can make a referral or can signpost you to where support is available. So very much this is a journey that should be happening in collaboration with your healthcare professional, not your healthcare professional telling you you need to go away and lose weight. So in summary, we know that as obesity is a chronic relapsing disease, as is IIH, we're never going to get off that ride necessarily, but rather than that roller coaster, those ups, those downs, those loop-the-loops, with the right treatment for obesity, that ride can feel a lot more gentle and a lot more controlled. And ideally, what it should end up feeling like is like a merry-go-round. So you might be going up and down ever so slightly, but ultimately you are feeling more in control of your weight management. Thank you very much. And again, I'm very sorry I can't be there in person, but hopefully this will stimulate some sort of interesting discussion and has helped in some way. Thank you.